My talk will just focus on the resurgence of scarlet fever that we saw in the UK, which started in 2014, and really the focus of my talk will be around that first period, that 2014 year. So just a little bit of background for those of you who are less familiar with scarlet fever. Most of you will be aware that scarlet fever is one of many clinical manifestations of Group A Streptococcus, Streptococcus pyogenes. This is an organism that causes a very wide range of clinical diseases, from the relatively mild to very severe life-threatening conditions such as necrotizing fasciitis. Scarlet fever itself is characterized quite typically with sore throat, possibly with tonsillitis, fever, and sometimes headache, followed within 1 or 2 days by a fine pinkish red rash, as you see here on the slide. That rash can be slightly harder to see on more darkly pigmented skin, but it's usually quite sandpapery in its feel, which can help to reach a diagnosis. And also accompanied by this typical flushed cheeks, which actually is how scarlet fever gets its name. It's from the actual flushed cheeks, and this swollen strawberry tongue that is quite characteristic of scarlet fever. Thankfully, Group A streptococci are universally still susceptible to penicillin, so penicillin remains our first-line agent of choice for treatment of scarlet fever and other manifestations of Group A streptococcus. So just to give a little bit of historical context, scarlet fever was made a notifiable disease in 1899, and the reason for this is that at that point in time, it was a very severe childhood infection, so really quite different to the scarlet fever that we see today. So around this period, we have data from the notifiable disease register, and this shows that between around 100 and 150,000 notifications were made each year in England and Wales of scarlet fever. And of those, we can record around 3,000 to 5,000 deaths per year. Now, they're almost certainly an under-ascertainment of the true burden of scarlet fever at the time, but we can appreciate that it was a very, very serious and common childhood infection. So the notification was made as a way to try and help control scarlet fever. And what we can also see is that there were epidemic years of scarlet fever, as shown here by these large upsurges in disease that happen typically around every 4 years, so similar to the pertussis cycles, which happen roughly about every 4 years during the last century. So as a result of these epidemic cycles, it was made notifiable, and this would help in enforcing public health actions around that time. This painting here by Lowry gives a nice example of one of those key public health actions. This would have been a common sight in British streets around the 1930s when this was painted, and it depicts the fever van, which is the title of the painting. And the van here would pull up in the streets, and children and possibly some adults who had developed scarlet fever overnight would be taken off in the van and taken to fever hospitals around the country, where they would be kept in isolation away from their families and friends until they recovered, or unfortunately, of course, for some of them, there would be no recovery, and that would be the end. So, mercifully, the incidence and mortality of scarlet fever fell dramatically over the course of the last century, so as we see here, and that drop predates the widespread availability of antibiotics, so clearly it wasn't just due to the availability of antibiotic treatment. We don't know why that fell in incidence happened. It's quite likely that there was a change in the virulence of the pathogen itself, and that's why the incidence and the mortality fell. Now, we routinely monitor our case numbers for scarlet fever as it remains a notifiable disease, and you'll see some slides later on which will explain why we monitor this quite closely. And it was through this monitoring that we noted an unusual rise in scarlet fever incidence at the beginning of 2014. So the next set of slides will give you a little bit more detail around those cases that we saw. So just to give you a little bit of background in terms of recent epidemiology for scarlet fever. So in a typical year, so this is 2010-11, 2012-13 season, we see around about 4,000 cases of scarlet fever a year. So that's a sort of pattern that we've been seeing for the last decade or so. Now, we received an alert from our health protection colleagues in the East Midlands in February of 2014 that they were seeing really quite an unusual number of scarlet fever cases. And in fact, shortly we saw this. And so our scarlet fever notifications just escalated enormously, and we saw a magnitude of scarlet fever that we hadn't seen for really quite a long time. So the incidence of scarlet fever peaked just before Easter, which is quite typical of the scarlet fever season. So the seasonal pattern was as per usual, but just a huge elevation on our normal incidence that we see in this country. So across the entire season, we saw 14,000 notifications of scarlet fever. So that's a rate of 26 cases per 100,000 population, which was more than 3 times higher the number that we'd had in the previous year. So in response to this rise in scarlet fever, an incident management team was convened in March of 2014 to coordinate our response to the rise. And there are a number of strands of this incident response, and I'll go through these each one just to give you a flavour of some of the activities we've been undertaking since then. So the first thing, of course, we wanted to do was to characterize our cases to see if they were similar to cases we'd seen in previous years, or was there something different about them, and of course, where exactly the incidence was higher. So this map here gives the incidence of scarlet fever in our health protection team. We have 24 of those, or we had 24 at the time. And what we could see is very quickly that every single part of the country had an elevation in disease incidence. There were some areas more badly affected than others, but there was no area that didn't report or see an elevation in disease incidence. And so for looking at the age distribution of the cases, so you'll see lots of graphs now that will compare 2014, our upsurge year, with the previous year. And what you can see is the age distribution was very similar to our previous year. So the red line here are our 2014 cases. So primarily a disease in under 10-year-olds, so around 90% of cases being in under 10s, but with small numbers of cases in adults as well, which is quite typical of scarlet fever. It's not entirely confined to the childhood period. So the 4-year-olds were most commonly affected, which was the same as we'd seen in recent years, so no change in that pattern. And we have some information on patient ethnicity supplied to the health protection teams. And again, just comparing the 2013 and 14 data, no real difference here. Majority of cases in white children and adults. So no obvious difference in the demographic patterns in the cases that we saw during the upsurge period. Now, one of the things we were very mindful of is that as we publicized the rise in scarlet fever and made sure that health professionals were aware, this would change notification practice, potentially. And so this might mean that we would start to see an artificial elevation in notifications, which was just down to better notification by GPs. So we wanted to look for other sources of data to help to quantify the rise in scarlet fever. So we worked with colleagues in the West Midlands who run the primary care surveillance unit. And what they have access to is some fantastic data from Sentinel GP practices. And we use that as an alternative means to look at scarlet fever incidence. And this is data based on a network of GP practices. And it allowed them to estimate the rate of infection in the country and the total number of infections that were seen by GPs, rather than just the ones that were notified to health protection teams. And the bottom line is that from that estimation, we worked out that there were probably around about 26,000 cases of scarlet fever seen by GPs, compared to the 14,000 or so that we'd had notified in England. The key thing here is that we're always aware that notifications are under-report cases of infectious diseases, especially some, such as scarlet fever. But what we were also able to do with this analysis is compare 2013 to 14, just to see if that magnitude of rise that we saw in the notifications was real, or whether, in fact, it was a certain amount of that was actually down to artifact. And so using the same methodology, the unit identified that there were probably around about 13,000 cases for 2013. So that would suggest that, in fact, the threefold rise that we thought we were seeing was perhaps closer to a twofold rise. So it substantiated the fact that there was an elevation, but perhaps suggested it wasn't as large as the notification data on its own would suggest. Okay, so there were 5 different strands to the public health response, as I mentioned earlier, so we'll go through each of these one at a time. The most important one, of course, is the communication, to make sure that frontline healthcare professionals are aware of the rise in scarlet fever. And so we had a series of cascaded alerts and letters and briefing notes that went to different professional groups to make them aware of the rise in scarlet fever and, importantly to us, the potential for a rise in invasive disease. So briefing notes were issued to health protection teams who cascaded them on to to regional microbiologists and to directors of public health. Letters were sent by the health protection teams to the local GP practices, A&E departments, and to schools and nurseries. We also issued alerts via various professional networks, including British Infection Association members, and to intensive care specialists, again, with in mind that we may have seen a rise in invasive disease, so we wanted people to be prepared and forewarned for that eventuality. We issued health protection reports every 2 weeks that gave an update on the case numbers. And we also reached out to our international colleagues to say, hey, this is what's happening in our country. Are you seeing something similar in your countries? So we reached out to the reference laboratories in other countries. We informed ECDC and put out a small article in Neurosurveillance to let other member states know of our problem. Our press office were kept very busy, as you might imagine, so they issued press statements every 2 weeks giving an update on those case numbers. There was a certain amount of uptake in the media, both in the broadsheets and broadcast media, and of course in the trade press as well. So there were a number of articles in Pulse and various other newspapers and journals for various healthcare professionals. So that was quite good to see. And the other thing that we were able to detect was that the message did seem to be penetrating through to the public, the message being that scarlet fever is something that does need treatment, and you must take your child to your GP if you think they have scarlet fever. And these data here show Google searches from UK IP addresses where somebody's put in scarlet fever as a search term. And as you can see, during the peak of our upsurge in 2014, there were nearly 1 million Google searches of the word scarlet fever from UK IP addresses. And they weren't all from me, I can assure you. Some of them were. Okay, so our second strand was to monitor the levels of invasive group A streptococcal disease. So why were we so concerned about this? Well, for this reason. The reason that we'd always been keeping a close watch on scarlet fever notifications is that we knew that historically there was a quite close association between scarlet fever weekly case numbers and invasive group A streptococcal disease case numbers. So what you see here is data from 2003 onwards, and you see in the blue is our scarlet fever counts, and the red are invasive group A streptococcal disease counts. And you see in each year that the two go up at the same time. They share the same seasonal pattern of a rise with a peak usually in March or April. So here you can see both going up and down at the same time. So there does seem to be an association between the two, which makes sense, as they're caused by the same pathogen. And so if you correlate the counts of scarlet fever with weekly counts of invasive disease, then you do see quite a strong correlation. So given that historical pattern, we were bracing ourselves, thinking, well, more scarlet fever, this means more invasive disease. We don't like the look of this. Thankfully, it hasn't happened yet. So these are invasive group A streptococcal diseases. So the red, again, is the 2013-14 season. So the peak of scarlet fever was around here. and the invasive disease was there was no escalation. It was very similar to the numbers from the previous year, if not slightly lower. That's invasive disease across all ages, and if we look just at invasive disease in children, again, the red bars were in fact lower in some parts of the year than the previous year. So no escalation in invasive disease, which was a great relief. Okay, so our third strand of our response was to develop some guidelines for health protection teams and how to manage scarlet fever outbreaks. We were getting lots and lots of calls from health protection colleagues wanting to know how they should manage outbreaks. In particular, was it worth going in to screen children in schools where they were having outbreaks? So we quite rapidly pulled together a guideline to help our health protection colleagues. And it would tell them how to respond to both a single case of scarlet fever and an outbreak. And the idea being that then there would be some consistency in that response around the country. I won't go through the entire algorithm, there's a lot here, but in essence it made sure that there was a commonality in the way that cases and outbreaks were recorded by health protection teams, which would mean that we would have important, comparable data from around the country, which we recognize we probably didn't have before. And also, just as one part here, just to highlight, this bit of the algorithm tells you what to do if you're in an outbreak situation. And it outlined indications for stepping up public health actions. So things that might make you locally decide to do something more if you have an outbreak in a school. And so these indications would be an outbreak running for a long period of time, or importantly, co-circulation of chickenpox. Chickenpox and group A streptococci are a very, very bad combination. So these would be the indications for stepping up some public health actions within a school outbreak. So what did the outbreaks look like? So we had 81 outbreaks logged by health protection teams in 2014. So quite a few more than in the previous year, where there were 38. So a real escalation in outbreaks managed by health protection teams. This is a considerable workload for health protection teams and still is to date. The monthly frequency of the outbreaks was broadly similar to the seasonal pattern of scarlet fever. A bit of an elevation here in May, which will be due to the publication of those guidelines in April, which tried to ensure some consistency of logging of outbreaks within our incident management systems. The majority of outbreaks were in schools and nurseries, so around 90% in those two settings, but there were a few other settings as well where outbreaks were recorded. Okay, so the fourth strand of our response was to try and assess the frequency of complications and severe outcomes. So again, it was just to try and assess, was this more of the same? Was there any evidence that these scarlet fever cases were more severe? Were there more complications than in previous years? So we came up with a number of different indices that we were interested to look at. So a number of factors relating to the scarlet fever presentation itself, such as the number of related hospital admissions, any deaths that were associated with scarlet fever, and pediatric intensive care unit admissions. We then looked at a number of different complications of scarlet fever, potential complications of scarlet fever, including acute rheumatic fever, glomerulonephritis, and other immunological sequelae. Now, of course, a lot of these complications are not specific to group A streptococci. They could be caused with a whole range of different pathogens. So looking for trends in those would be slightly hard to interpret, as you wouldn't be sure that it was really related to scarlet fever as opposed to something else that was happening in the population at the same time. So what I'll do now is just give you just a little flavor for some of this. I won't go through all of this, but just focusing on the top part here, which was actually looking at the scarlet fever cases themselves in a little bit more detail. So one of the things we've decided to do in response to this is to try and augment our scarlet fever notifications through data linkage. So what we have done is that we've taken the scarlet fever notifications as well as other case reports that were made to health protection teams but not formal notifications. And there were 19,000 of those in these 2 years. So again, keeping in the 2013 to give a baseline comparison. And those cases were sent to the demographic batch tracing service, which does two things. One, it confirms the NHS number that we have for the patient and completes it if it's missing. And importantly, it tells us if the patient's still alive. And through that, we were very pleased to see that there were no attributable deaths within those patients. There were a small number of deaths, but once we investigated, we could see that the death was clearly not related to the scarlet fever. So that was reassuring. And so that left us with 18,479 patients with an NHS number that we could then use to link to hospital episode statistics. Most of you will be familiar with these, but in case some of you are not, this is a giant data warehouse that contains information on all hospital admissions to NHS facilities in England. So what we were able to do is use the NHS number to link these scarlet fever cases to all the admissions to hospitals in England. So what we decided to do is to link to admissions that occurred in the 7 days before the scarlet fever onset or notification. Now, the reason for that is that for many of these cases, we didn't have a very precise date of onset, so we didn't want to lose the ones that we were notified about somewhat late, and up to 30 days after their scarlet fever onset. So from this data linkage, we have 893 linked records, linked patients. So in other words, 893 of those 18,000 odd patients had a hospital admission within the 30 days of their diagnosis. So we can look at these in a little bit more detail and compare the 2 years. So those linked admissions are listed here. So for 2014, there were 656 hospital admissions in those scarlet fever patients. So that represents 5% of all the scarlet fever cases in that year. Compare that to the 2013, obviously a much lower number. So there was almost a threefold increase in the number of admissions between the 2 years. But actually, proportionately, it was very similar. So there were around 5% of these cases were admitted in 2013. So again, that was quite reassuring that even though we were seeing more hospital admissions with scarlet fever, proportionately it wasn't more. It's the same sort of ratio as the previous year. We have been attempting to look at the hospital admissions in a little bit more detail. So these are all cause admissions, so the patient may have been admitted for a completely unrelated reason, although it was reasonably close in time to their scarlet fever diagnosis. This is quite tricky to do. If any of you've used HES data to try to analyze the clinical codes, some of them are quite non-specific. So we're not managing very well to get an accurate picture from some of the codes. But for this set of patients, the codes were very, very clear in terms of the reason for their diagnosis, their admission. So a third of those admissions in both years were coded specifically as for management of the scarlet fever infection, and then around a fifth for tonsillitis, pharyngitis management, so very closely related, of course, to the scarlet fever. The remainder were a mix, mainly of other conditions, potentially complications of scarlet fever, so a whole range of different conditions. No rheumatic fever cases, I'm glad to say. Slightly worryingly, we had 2 cases in each year that were coded in HES as having sepsis. So that's certainly of some concern. But again, no elevation on the previous year. So it looks from the scarlet fever linked hospital admissions that it's very much more of the same. So a considerable additional burden, but nothing to suggest a more severe clinical presentation. So we can look in a little bit more detail around those 2014 hospital admissions. So what we can see here is the age of, these are all the notifications in the grey, and the blue line gives you the admission rates, the proportion of all notifications by age who were admitted to hospital. So I said around 5% of all the scarlet fever cases were admitted. that's correct, but actually when you look at the younger ages, then that proportion is much, much higher. So in infants, it's just over 8% of those patients were admitted to hospital. So the median age for those admissions was 4, and we saw, as I said, a much increased rate of admissions for the younger cases. The median interval between their scarlet fever diagnosis and their admission was 3 days, but it varied quite a lot. And the length of stay was very variable. Now, to be in HES as an admission, it means you are formally admitted to a ward, but doesn't mean you're necessarily kept in overnight. Some of those will be short-stay observational assessment wards. And in fact, the majority of those admissions were actually discharged rather than staying overnight, with a range of length of stay up to 16 days. So we can look in a little bit more detail at the patients who were admitted for an overnight stay, so who stayed in for more, who weren't sent home the same day. So there were 298 of those out of the 656. So it's around about half of those admissions were kept in overnight. So that represents 2% of all the scarlet fever notifications in that year. So if again, we can compare that to the year before, and that just shows really quite a large increase in that burden of hospital admissions with an overnight stay of more than doubling from the year before. So quite an increased burden associated with this upsurge. Right, so lastly, the million-dollar question was trying to investigate why we were seeing this rise in scarlet fever. So this is the question we all wanted to know the answer to. So we've undertaken some analysis to try and investigate this. Our real focus has been on microbiology to see if there was anything about the isolates causing scarlet fever that would answer the question as to why we were seeing more scarlet fever. Perhaps there was a new strain that had been introduced into the population, and that would give us the answer. So we sort of spent quite a bit of time on this. So a sampling frame was devised, and that would involve regional microbiologists being given a target number of throat isolates from scarlet fever patients to send the isolates to the reference laboratory for that further examination of those isolates. So this was undertaken in 2014 again, and quite disappointingly, the isolates were subject to EMM typing, and there was really quite a diversity of different types. There was a bit of a dominance of EMM3, although there was the regional distribution of those isolates was not even, so some regions didn't manage to make their targets. So in fact, once you take that into account, the EMM3 is even less dominant than it is in here. But clearly there was not one single EMM type that was causing the scarlet fever in these isolates. So that was a little bit disappointing, as it was starting to suggest that the answer was not going to be in looking at the bug. And of course they couldn't resist but doing some genomic sequencing of these isolates. And again, it just supported the fact that there were multiple lineages amongst the scarlet fever cases, and there was no single mobile genetic element, a phage or something like that, that was common between those different EMM types. So really a very diverse range of strains within the scarlet fever cases. What's also interesting, and we're starting to understand a little bit better now, is that on this phylogeny tree, underneath that you can't really see very well, you'll just see some dark colour. And the dark colours underneath, which are actually little black squares, represent the diversity of strains causing invasive disease. So those were plotted on the same tree. And in essence, what this shows is that the scarlet fever cases were no different to the ones causing invasive disease, which is a slightly chilling prospect. Okay, so it looks like the bug is not the answer. At least that's what our initial analysis shows. So it's kind of back to the drawing board in terms of trying to work out why we're seeing such a lot of scarlet fever. So I've gone back and looked at the historical data as people will ask time and time again, well, maybe this is just something we see every now and again. And I did mention at the beginning that we'd see these sort of epidemic cycles, or have seen these epidemic cycles, And certainly if we look back at some of those swings in disease incidence, they were very dramatic. They tended not to be, though, quite as dramatic as the one that we've seen. So generally speaking, they wouldn't have gone up to the sort of threefold elevation in disease incidence that we've seen between 2013 and 14. So there isn't really very strong historical precedent for what we're seeing, not least that over the course of the last century, those swings in disease incidence became much, much less marked. So certainly what we're seeing now is really quite unusual, even when you look at the data historically. What that historical look also tells us, though, is that where you did see a large elevation in disease incidence, it was often preceded by 1 or 2 or maybe 3 years of sort of intermediate high incidence. Not always, but often it was. So what does that tell us? So that tells us, of course, that the rise in 2014 was not necessarily the end of the story, and that we ought to be watching out for 2015. Now, to look at those historical patterns in more detail, Stephen Rushton from Newcastle University has been doing some very fancy wavelet analysis, which I don't understand at all. But what it effectively shows is here, this is the nicest statistical report I think I've ever seen. It's a really nice heat map. So what you have at the bottom is an axis which gives time. So he's taken the whole historical data of scarlet fever to look for cycles or evidence of cycles of increased incidence using this wavelet technique. So you go from 1912 here all the way along to more or less where we are now. And here you have on the y-axis, you have the period from no cycling up to 4, 8, 16, and 32-year cycles. And it is a simple heat map in a way, so what you're looking for is the darker colors. Darker red colors tell you there's a statistically significant evidence of cycling. So at the beginning of the last century, you saw a strong dark red here that shows that aligns with the 8-year cycle, and then a 4-year cycle you see here as well. So at different parts of the century, there were slightly different cycling patterns that were seen. Some of them you could see them descriptively. You don't need to do this sort of fancy analysis. But one thing he did say to us, which we hadn't really appreciated, is that at the bottom here, there's a sort of orange glow. It's not a deep red, so it's not very significant, but there is an orange glow here around about the 30-year mark. And what this suggests is that there could be a 30-year cycle in scarlet fever incidence. We'd really need sort of longer-term data to be sure of that. But it may be that what we're seeing now connects with this 30-year cycle. So, in summary, we've certainly seen a very remarkable increase in scarlet fever in 2014, with the highest number of notifications that we've seen since 1969. All the analysis that we've done so far has failed to show any disproportionate rise in any population subgroup. And whilst we are, of course, seeing an increase in complications and hospital admissions for scarlet fever, they don't appear to be disproportionate in terms of the numbers of scarlet fever cases. But altogether, 1 in 20 of our scarlet fever cases did have an associated hospital admission, which is quite worrying. There was a substantial increase in outbreaks, and this has been really quite burdensome for health protection teams and for schools to manage and nurseries. And thankfully, there's no evidence to date of a widespread increase in invasive disease. I say to date, the early part of this season was starting to look a little bit high, but nothing dramatic, so we're keeping a very close watch on that. So what does the data look like now? So that was the 2014 peak that we've talked about, and I've showed you lots of data on. The following year, even worse. So we had over 15,000 notifications of scarlet fever in 2015. So we thought 2014 was bad. It got worse in the following year. So far this year, it looks like this. So that's the yellow line. So we've been skirting just above what we saw last year. Bit of a dip here. You always have a dip around Christmas. Christmas holidays help to break transmission. Kids go back to school, and you start to see the elevation now, which will really continue. There'll be a little bit of a dip with half term, and then it will just go up and up. So we're a little bit worried about this year. It looks like it could be another bad year, but we wait to see. Perhaps not. So in conclusion, so the increase in scarlet fever that we've seen in the UK is not something that has been seen elsewhere in Europe. We had a couple of countries respond to our Eurosurveillance article saying, oh, we think we might be seeing more scarlet fever, but they have no data really to substantiate that. So as far as we know, we're the only country in Europe to see this. But interestingly, there are a few countries in the Far East which have reported a rise in scarlet fever in the recent periods. So Vietnam was the first, followed by Hong Kong, and then reports from mainland China suggesting a real elevation in disease incidence. Now, those cases were quite severe. There were fatalities that were identified in those countries. This may well be there around the management of those cases. So our genomic analysis of the strains doesn't show that there was any introduction of a novel strain or a proliferation of a specific strain. We did find a phage which was similar to the one identified in the Hong Kong upsurge, but again, this phage wasn't very dominant in our strains. It was there, but it wasn't very, very common. So again, it doesn't look like the strains are the answer for why we're seeing the upsurge. So the reasons for the upsurge remain really very poorly understood. We have been hypothesizing various things. Nothing is very strong at the moment. There is, of course, a possibility. It's not a very popular message to be putting out at the moment, but there is a possibility that successive undertreatment of group A strep, sore throats, and other superficial presentations has led to an increased prevalence in group A streptococci generally, and that this has caused the rise in scarlet fever. We don't have strong evidence of this at all. There was a nice paper written by Jeremy Hawker and colleagues that shows a drop in antibiotic prescribing for sore throats in primary care. So not the usual pattern where we're seeing more antibiotics prescribed in primary care for sore throats. But nothing, no recent data to really support that there has been a big change in prescribing practices. Of course, it may not be the prescribing once somebody turns up at the GP. It may be that some individuals are not going to the GP, so they're actually sort of taking themselves out of that position where they might get antibiotic treatment. And of course, as we already mentioned, there is a possibility that what we're seeing is just part of some natural longer-term cycle in population immunity. And it remains for sure that if we don't understand what's driving the rise, then we're in a little bit of a difficult position in terms of knowing what might work in terms of prevention. So we do carry on and try and test some of these hypotheses to see if we can understand what's happening at the moment. Okay, so it just remains for me to thank the members of the incident management team. This is an incident management team across the United Kingdom. So we had members from Public Health England, Health Protection Scotland, Public Health Agency of Northern Ireland and Public Health Wales. Mary Ramsey and Alan Johnson were the chairs for the incident management team over the last 2 successive years. And my thanks to the health protection teams for the great job they've done in logging cases and outbreaks in HP Zone, which is our software application for case management and outbreak management. And to all the laboratories who submitted isolates for testing and all the notifiers around the country for their efforts with this, and the real-time surveillance unit in the West Midlands. Thank you.